Thanks, Dr. Becker, for the introduction. One of my fondest memories, I trained in Calgary and finished about 10 years ago. I'd spent some time with Dr. Becker, was doing clinic with him, of course, and everything I learned about headache medicine from him, but also Scott Jarvis will know about this. At the Foothills, neurology is on the 12th floor of the hospital. And when we were on service with Dr. Becker, we were never taking the elevator. We took the stairs. I still have PTSD from that. But very healthy habits I learned early, and most of what I know about headache I also learned from Dr. Becker, so thank you. I'm a pediatric neurologist, and I have an interest in headache and facial pain disorders in children. And I'm just curious of how many of you work with children or have children with headache or pain disorders? Okay, good. Oh, good, good. Okay, great. I'm happy to hear that, because I always feel like children are maybe not paid as much attention to in terms of their experience of pain in various conditions, and in migraine in particular. I have 15 minutes to chat to you about this, so I'll just get started. These are my disclosures. I've served on some advisory boards, and I'm happy to say that I'm a site PI for some clinical trials in pediatrics, and it means the field is evolving. And so these sponsors have been great in seeing an interest and contributing to the care of children with migraine. I have some funding from those societies, and I also serve as a guideline co-author, but for alternative and complementary medicine, so not on the topic that I'm speaking on today. So what I'd like you to take away from this talk today is just simple things. The ability to distinguish between pediatric and adult migraine. There are some subtle differences in the diagnostic criteria, but it's important to recognize when migraine occurs in children so that we can treat it. And then we'll go through some acute therapies that have been tested in children for the treatment of migraine, and understand that similar to adults, there are some combinations that can create synergistic effects. So we can and should try to prescribe these treatments for our pediatric patients to help them feel better, and we can do so safely with evidence behind it. And then I'd like everyone to feel comfortable walking away with an idea of how to develop a safe and effective acute migraine rescue plan for their pediatric patients, considering certain sort of pediatric unique needs that population has. So, talking about pediatric migraine versus adult migraine, headache is actually a really common problem in children, and I think we're all here pain specialists and interested in different types of pain, but in children, headache is quite a major issue. It affects up to half of early school-aged children, and 3/4 of adolescents also. And recurrent migraine can affect about 1 in 10 children in the sort of 5 to 15-year-old age group, which means every classroom has 2 or 3 kids that experience migraine. And so it's something we should all be aware of. We may have them in our homes as our children, or we may have them just in society as just children at school and whatnot. So it's an issue that we should all be aware of. And I wanted to highlight PCAN, which is a new organization started about 3 years ago now, Pediatric Canadian Headache Network. We're a group of about 10 pediatric neurologists, some nurse practitioners, general pediatricians, all interested in improving the care of treatment of headache in children. And so we meet quarterly. We talk about current sort of research projects, difficult cases, and also clinical trials, and how to improve care for these patients nationally. And so finally, the field is coming to a place where we're working together at a national level to help kids with migraine and headache. So migraine in kids is a problem that evolves, and prepubescent in the prepubescent group in early childhood, boys tend to get migraine more often than girls. And then once puberty hits, there's a sharp delineation you can see there where there's a takeoff, and girls experience it more often than boys. And the prevalence sort of increases to adult levels in sort of the late adolescent stage. And that is largely hormonally involved, especially in the female group around the time of puberty. This is really interesting, and I'd like anyone that takes care of kids in general to recognize that there are expressions of migraine in childhood that are not just headache, photophobia, nausea, vomiting. And I think if we can recognize these, maybe we'll also try to treat them better. In infants, it's now known and thought that infantile colic is actually one of the first manifestations of migraine in our lifespan. And so babies can have episodes of facial pallor, irritability, sleep and mood disturbance changes that are now recognized as an early onset manifestation of migraine. Sorry if there's any feedback. Prior to puberty, there are these sort of subset of syndromes known as episodic syndromes associated with migraine. And they are essentially brainstem phenomenon that are migraine-related precursors that don't have the full sort of experience of head pain yet, but have a lot of symptoms of vertigo. So benign paroxysmal vertigo are episodes where children, usually toddlers, can get very, very pale, vomit, and have severe vertigo. There's benign paroxysmal torticollis, where toddlers will often get very pale, vomit, and have their neck stuck in a sort of torticolic position. There's abdominal migraine, where patients will often just get severe abdominal pain with no head pain, but pallor, nausea, and vomiting also, and then cyclic vomiting syndrome, which is just recurrent episodes of severe vomiting with no head pain associated. We now know these to be precursors to the development of migraine in its adult phenomenon, and it usually is expressed as the more sort of adult, grown-up version of migraine around puberty. And then we do see our teenage patients behave like adults with respect to their symptoms of migraine. But really, the differences are subtle once you get to the sort of post-puberty age group. We can see there that in terms of the criteria for migraine, kids can have migraines that are a little bit shorter, so lasting, in our criteria, 1 to 72 hours, and the pain can be bilateral, does not have to be unilateral, but otherwise the features are pretty similar in our adolescent age group. I apologize that this is a bit busy, but I really wanted to show this to you because this was the topic of my talk, and PCAN and Migraine Canada, we've actually teamed up together with the Canadian Headache Society also to create this infographic, which you can find at that website there, where all of us reviewed the available evidence in children and created this therapeutic sort of management plan of suggestions on how to treat acute migraines in the pediatric population. And I'll spend some time focusing on the details of that in acute migraine in particular, but I would like to all be aware of this. We've spent some time looking at the dosing and have suggestions that are evidence-based here, so please refer to it when you are prescribing for these patients. I know sometimes in clinic it's hard, and I feel with pediatrics people are always worried, oh, this one weighs 20 kilos, how do I dose this medication? Even I sometimes sweat that myself, so you have to double check, and that's stressful. So there's a really nice resource on this website that I hope will be useful to people that care for kids with migraine. We're not talking about prevention of migraine today, but there are some useful elements discussed in that infographic also about self-management recommendations and preventative strategies also, so please take a look. But in terms of acute therapies for pediatric migraine, really, I'm happy that my talk is a little bit redundant to Dr. Muzagar's. I want to reassure you that how we treat kids with migraine is quite similar to how we treat adults with migraine in the sort of acute aspects and approaches to acute therapy. So first line, most of the evidence is in favor of ibuprofen. I like personally using naproxen. It lasts a little bit longer for the patients, and you can see dosing there. Between ibuprofen and acetaminophen, ibuprofen comes out on top for kids, so I would prefer if there were no contraindications if that was used for a child with migraine first. And then there are actually quite a few studies, including an FDA approval for rizatriptan. And so studies supporting the use of triptans in pediatrics, and if there's one thing I can ask you to take away is please do consider prescribing a triptan for a child with migraine. Unfortunately, we're doing some research right now looking at prescribing practices for children with migraine, and often opioids will be prescribed before a triptan will be prescribed, and that's very unfortunate in the pediatric population. So please do know that there are tested and safe triptans. Typically, we'll tend to start in our program rizatriptan or almotriptan if you would like a Health Canada approved version. Almotriptan is one that I would recommend, and you can see the dosing there. So in terms of treating acute migraine, I think it's important, and Dr. Muzagar already alluded to some of this, first you want to establish the specific headache diagnosis. If you're going to use triptans, it should be a migraine. It won't work well for, a tension type headache, so be comfortable in recognizing migraine in children. Once you've established the diagnosis, again, like Dr. Muzagar said, we want treatment to be fast and complete in terms of pain relief with minimum side effects. And ideally, it would also address some of the associated symptoms of migraine, like nausea, vomiting, photophobia, or photophobia. Like in adults, we know that improved efficacy is seen in children with early treatment. So I encourage my families and patients to take their medicine with them and put it everywhere. Put it in your backpack, put it in your wallet, put it wherever you can get at it. Schools sometimes make this a little difficult. They want letters or they don't let children take medication, but if you can provide documentation for schools, it's very helpful so that kids can request and get their treatment right away. It often means they can rest in the office for a bit and they don't have to miss school. Moms and dads don't have to miss work because that burden is quite huge for families. Similarly to adults, we do always suggest if you fail one triptan, try another one in two ways. So if you don't respond after the first dose, you may repeat a second dose, and 2 in 24 hours, similar to adults. And then if you don't respond well to one formulation, try a different company, try a different formulation. We will do the same in pediatrics also. And of course, try different formulations also. Sometimes kids don't really like it, but intranasal sprays, subcutaneous options are also available. And then this is not yet sort of covered for kids, but the combination sumatriptan naproxen combo does work quite well. And so I've had some difficulties with insurance companies in terms of getting it covered for children, but sometimes I'll prescribe both of these separately for kids that may have failed a simple first-line approach of an NSAID or triptan. So when you're designing a treatment plan, we certainly don't want to cause harm, right? So as Dr. Amuzagar mentioned, we don't want to recommend that a patient enter into a medication overuse state with any of the medications we prescribe or any of the over-the-counter options they have available. I really, really would like to highlight that opioids are not indicated for the use of acute migraine management or acute headache management in children at all. I know there's a place for it and there's lots of anesthesia friends and colleagues here that use it well for other conditions in pediatrics and adults pain management, but for migraine itself in kids, there's no indication, and we certainly don't prescribe it in our program, but it does get prescribed a lot for children outside of our program, so hoping that can change. You know, for kids, it really should consider things like their age. I get the cutest comments. They hate the way, I don't want to out like certain companies or products, but some of them just taste funny. One tastes like anise, or one tastes like whatever is, you know, this, they just don't like the taste. So they will complain to you, please don't prescribe it, because it works. And I just try to say, just try it once and you'll feel so much better. They usually do come back and say, Dr. R, it did work, but it tasted horrible. Many kids don't like needles, and so like Dr. Jarvis was talking about, we do occipital nerve blocks for children. This is an acute migraine talk, but we do them in the acute state in the emergency department for rescue of sort of status migrainosis in kids and teenagers. The youngest we've done is 8, so you could get an 8-year-old to do it. It takes some work, but it can be effective in that age group also. But many are afraid of needles, so that's sometimes a limiting factor for us. And then parental insurance coverage. A lot of the medications I'm talking about today, some of them are just not covered or poorly covered by parents' treatment plans, so it's often very hard to know until you take the prescription and go to pharmacy, but just be aware of that. Of course, we want a treatment plan to be safe, so triptans should not be prescribed to people with a history of ischemic vascular disease or accessory conduction pathway disorders. I follow that same sort of precaution in children also. And I do counsel teenagers to take their triptan during a typical aura. The previous teaching of waiting until your aura has passed is sort of an antiquated recommendation now because we've improved our knowledge of how migraine aura occurs and how triptans work. And so we know that the triptan may be more effective if you take it at the onset of head pain, but really just encourage patients to take it quickly. And then do consider referring, if you have any pediatric patients with sort of more rare migraine subtypes like hemiplegic migraine or migraine with brainstem aura, consider referring to a headache specialist either here or my colleague Serena Orr, who's speaking I think tomorrow or Saturday in Calgary, also has a similar program at the Children's Hospital in Alberta. We're happy to help and take questions either through phone call or by referral. It's a rarer subset of headache disorders that you might want some assistance with. So when we're treating associated symptoms, very similar to what Dr. Muzagar also said, unfortunately we don't have clinical trials specifically designed for the associated symptoms of pediatric migraine, but we do extrapolate from safety perspective and know that these medications have been used in children with other conditions like gastroenteritis and chemotherapy-related nausea and post-op vomiting. And so we do often recommend ondansetron, metoclopramide, and the dosing is also on that link to that Migraine Canada sheet I told you about. So please do prescribe those for patients. Sometimes the vomiting is worse than the pain, my patients will tell me. And both somatriptan and sumatriptan nasal sprays have been shown to improve the symptoms of severe vomiting in children in addition to head pain. When they're light and sound sensitive, these may sound very simple, but they help. Sunglasses, tinted prescription glasses, hats, things that we don't really think about or maybe are more pediatric focused. I always just encourage families and physicians to consider. And there is some evidence that somatriptan can be helpful in the treatment of photophobia and phonophobia in children, as well as the combination sumatriptan naproxen. Dr. Muzagar did mention the Canadian Migraine Tracker, which I also like using. I don't know if it's specifically indicated for kids, but all teenagers have a phone. Get them to download it. It's a very useful way to track pain and helps me see if any of the interventions I'm offering are actually helpful when they come follow up with me. We do want to prevent medication overuse headache, and then we want families to understand that there are limitations to current treatments, but there is a lot upcoming in what we're doing in clinical trials in pediatric migraine, so keep hope. Along that line, unfortunately, we're not involved in any acute migraine therapy trials right now. We were going to be a site for lasmiditan, but then the sponsor pulled that trial. And so right now, most of the work that we're doing in the Stollery, primarily in Alberta, I'd say the Stollery is probably the most active clinical trial site for pediatric migraine, is more in the preventative space. We are enrolling patients for studies of atogepant as a preventative treatment in episodic migraine, and also uptinezumab for the treatment of chronic migraine. The reason I'm telling you guys about this is because I just want you to know that they exist. If you have patients that are interested in clinical trials, I'll have my email at the end. I can be contacted for that. And the reason I like enrolling patients in this is obviously we want them to feel better, but often they will have open label extension access to this drug for up to a year, which is really nice when often these patients have failed all available therapies. And so this is one way for us to obtain these treatments for our patients. Just a few really quick cases and then I'll be done. So if you have a 12-year-old with severe migraine and vomiting, I'd like you to consider something like a buffered diclofenac. If they can keep it down, its Tmax is 10 minutes. So if they can keep it down and in, it can work quite quickly. And we do use that quite a bit in our adolescent population. Of course, you should also consider a nasal spray or subcutaneous triptan to avoid the GI route. And orally disintegrating tablets are also good as they can dissolve without water. If you have a little kid that can't swallow pills, I feel like having a migraine is bad enough. Probably rectal NSAID use is not the nicest thing to do. You could. Naproxen liquid also exists, so anything that's not a pill. And then also there's orally disintegrating tablets for both triptans and antiemetics, so please consider prescribing those for your patients. And if you have a 16-year-old, for example, that might be resistant to just triptan alone, please do consider combining an NSAID with a triptan. We have evidence of synergy in adults, and we do use that same sort of pathophysiology sort of thinking in treatment of adolescents also, and then ondansetron can also be added to that. So in summary, childhood migraine can present differently from adults until about puberty, and so it's important to recognize this diagnosis so that we can treat it properly. Many acute therapies have been studied in kids and more are coming, so there is hope for kids out there with migraine. And migraine in adolescents, I would really encourage everyone to please try to treat their adolescent patients as they might treat an adult with migraine. Similar strategies can be successful in adolescents also, including triptan redosing, retrial of other triptans, early treatment, and synergy with NSAIDs and triptans. And we really can and should be treating childhood migraine early and safely. Thank you.